Hello and good day to you all. My name is Vinoj and I'm speaking to you from Delhi. A very hearty welcome to this breakaway session, Community Engagement Health from the Ground Up. If we map the care seeking pathways of any woman who for any disease or medical treatment, you will definitely find a female CHW playing a pivotal role in providing information, accompanying her to facilities, or providing essential products. Health systems, as many of us know, around South Asia rely heavily on the female community health workers, who are frequently the first point of contact for those seeking care. As Barka highlighted in the plenary just a few 15 minutes ago, despite their very vital role, these women are often at the periphery of the public health ecosystem, overworked but underpaid and unappreciated. In this session, we have a mix of public health specialists, researchers, and advocates who will dive into the challenges that female community health workers face on the ground and examine strategies to strengthen their capacity, better meet their needs, and ensure the voices are included in decision making. Thank you all for being here. Please remember, as the session progresses, to please type your questions in the Zoom chat box. We will address them through the session. Now is the time to go across Southeast Asia to meet our panelists. From New Delhi, we have Dr. Priya Karna, who is the Technical Officer for Reproductive Health at the WHO Country Office for India, a medical doctor and a public health specialist trained at the Johns Hopkins Bloomberg School of Public Health. She is very familiar with the health systems in Nepal, India, and the 11 member states of the WHO Southeast Asia region. From Pune, Dr. Nerges Mistry joins us. She is a microbiologist and immunologist by training and the director of the Foundation for Medical Research and the Foundation for Research in Community Health. She has done some seminal work on developing frontline workers to tackle complex health issues, including NCDs and maternal and child health. She was appointed as a member of the ASHA mentoring group in National Rural Health Mission. We also have Dr. Sabina Rashid, who is the Dean and Professor at the BRAC School of Public Health at the BRAC University. She lives in Bangladesh. Sabina is a medical anthropologist and an ethnographic and qualitative researcher. She especially focuses her work on rural urban populations, adolescents, and marginalized groups, enhancing the ability of these populations to realize their health and rights. Last of the panelists, Ms. Shanta Lakshmi Shrestha is from Nepal. Is an advocate for gender equality, women's human rights, and sustainable developments. Shanta, your achievements are very long and impressive. I am going to just provide a tiny snapshot. Shanta was the immediate past president of Beyond the Beijing Committee in Nepal and initiated the She Decides movement in her country. Author of multiple books and manuals on gender equality, SRH, abortion stigma, etc. She is the first woman national coordinator of the Human Rights National Magna Meet. Thank you all for being here. I would really like, at the start of the session, to put a human face to the topic we are discussing. Sabina, given your in-depth work at the community level and the various research that you have done, could you dig into your personal experience and your research findings to tell us why CHWs, especially female CHWs, are so vital for healthcare to reach community level?
Thank you very much. I always stop, I always forget to unmute myself. So thank you. I'm going to keep it brief because I know we have 3 minutes, but I do like your question because you said we're starting from a human dimension level. And I think that is the critical question we all need to address is when we look at community health workers, we're looking at human beings. We're looking at women who are on the ground working every day to address needs of vulnerable groups, vulnerable populations, marginalized groups, be it urban slums, be it rural areas. So I wanted to make a few key points based on some initial research we did during the COVID impact. As you know, we've been doing a series of assessments because, we're the James P. Brown School of Public Health. We were set up by BRAC, the NGO, but we're an independent academic institution. And what we found is many of the community health workers are extremely committed. So they really are committed, but there is a very, very strong tension between their commitments and the realities on the ground. So they kept talking about wanting to serve, wanting to go out and give information, but there's a disconnect because many of the communities, first of all, cannot afford soaps or masks. You're talking about poorer communities who don't have the luxury of buying soaps and masks. And for them, these messages are useful, but they would tell the community health workers, ask your organization or ask the government to give us masks and so. This is at the height of the pandemic. Of course, it's reduced now, the fears. Secondly, community health workers, and there's variations within community health workers. I'm not going to go into those details. Some are paid more, some are paid less. They have different responsibilities. But one thing I heard was they felt like there was an additional burden. While they felt they wanted to inform the communities, there was also the pressure of household work, support from their own families about the fact that they're going out there door to door, and they were worried about infecting themselves or infecting their family members. They're worried about children at home. Because you see, from March till June, everything shut down in Bangladesh. We're in complete lockdown. So there was the gender dimension. There was highly stigmatized issues around COVID. There was a lack of communication from the community-centered approach, which meant that most of the communication was virus biology. It wasn't about, how do you resonate from a cultural, social perspective. That increased the stigma. That made it harder for community health workers because some were being turned away by households. Final point is that in the end, when we spoke to about, I think, 19 community health workers out of 80. And we're starting some ongoing research. But my final point here is that if we go back to the human dimension of community health workers, they're mothers, they may be sisters, they may be daughters, they may be whatever, single working women. The reality is with the COVID pandemic, they are in communities, many live in those communities. They felt extremely stressed out. And there's a lot of psychosocial stressors that we need to talk about. It's not just about money. It's about social support. It's about psychological support. It's about informing their families. It's about also working with community health workers so they can be more productive and effective because the commitment wasn't wavering. It was more the complexities of the issues as they were unfolding. Thank you very much.
Thanks, Sabina. That was a nice opening about getting them from their perspective. Priya, from a WHO's perspective, what does a successful model of leadership in community health force really look like? And given us the focus of the session, could you tell us how women-centric is this model?
Thank you so much, Vinoj, for that question. And at the very beginning, I'd like to thank everybody for joining in, as well as thank the panelists and presenting their views. It is a great opportunity and also very interesting for me to sit here and listen to everybody. Thank you, Sabina, for what you said. It really did bring a perspective. I'm happy to share a little bit about WHO's perspective, although I think 2 to 3 minutes wouldn't do justice to it. So I'd like to cover as much as possible and also share some ideas and some, hopefully, areas that you can access these documents. As you all know, WHO's primary role is in formulating guidelines, policies, providing technical advice. And one of the key things and key frameworks that WHO is guided by is the Global Strategy for Human Resources for Health. It defines the community health worker. It tells us about what kind of competencies they should have, what kind of education, what kind of career paths, etc. they have. All these frameworks are there and they are readily available in the WHO website. However, when we really look at what success looks like, we have to think about what a leader really looks like. I think Sabina also mentioned it. COVID has taught us one thing, that all our community health workers, they are all from the community. We have to think about what the community perceives them as. Do they really view them as leaders? Who are they? What kind of context do they thrive in? How are they supported by the government or by their local communities or the system or the environment in which they thrive? And what kind of services are they really expected to deliver? Within that context, within that framework, we have the Sustainable Development Goals, we have Alma Ata Declaration, we have the Human Resources for Health Global Strategy. The framework is there, but it's really taking that framework from guidance and from policy to action. And I think that, at this point of time, what we have really learned is that it comes from the community, trying to understand what their needs are and matching that with what the needs of the women themselves are. At the end of the day, they are people. They have to be answerable to that community. The community has to view them as leaders. So although there are frameworks, they are very well defined. They are written down in documents. We have so many of them, from what leadership should look like, learning from the Ebola pandemic all the way to its application in COVID. The documents and guidelines are there, but I think it's essentially about answering 4 questions, and that is who they are, what are we really doing, like what are the selection criteria, how are we identifying our community health workers, how are we building their capacity, not just for making them a leader in the community, but also a representative of the community that they belong. Because ultimately, like you said, Vinoj, they are the first point of contact, whether it is for reproductive health service, whether it is for door-to-door surveillance now. We really have to understand that when we burden the whole health system on them and expect them to deliver all of these things, are they really empowered and enabled? And that's where WHO's frameworks and guidance note comes in. But I think it's really up to the countries, and I think at least in the Southeast Asia region, specifically in the context of COVID, we've seen very good adaptations. One thing that stood out for me personally, I would say, is, we've all heard about the ASHA worker and, how the entire health system in India is pegged to the ASHA and the Anganwadi worker. They're all women at the end of the day. 11 lakh Anganwadi workers, 10 lakh ASHA workers plus. The numbers are outstanding. But, this is the one time in COVID that the government has actually made an effort to empower them. Insurance covers them. I think that is in and of itself is a big step forward. So while frameworks and documents, they exist, it is opportunities like COVID that I think has provided us with really, the chance or once in a lifetime, unprecedented time to apply this. And I think at least the government of India has taken concrete steps in applying that and taking that forward. So I think I'm within my 3 minutes. Over from my side, Vinoj.
Priya and the rest of you, please don't be too constrained about the 3 minutes. And I really hope that I'll be able to come back to you and look at continuing where you left a little later, right?
Absolutely.
So, Nerges, I read your time and motion study that you conducted on the community mental health workers in rural India. It's absolutely fascinating. In that study, you made a point about how non-value added activities consume a significant proportion of their time of the health workers at the expense of value added activities. Could you explain to us a little more about your study findings on that? And also tell us what's your sense of the applicability of this to the overall general ASHA cadre?
Thank you, Vinoj. Pleasure to be here, and thanks for the opportunity. So as Vinoj said, this was a research study. You must remember that. And it was undertaken around between 2013 to 16 when we were doing this project in rural Maharashtra in an area of about 70,000 population, staffed with 4 community health workers. And the tussle with the funder was, how many community workers do we actually need to actually cover this population for a complex problem like mental health. It's not something in mental health that you give a medicine and then you move away and the person gets cured or remains sick. But this is a chronic situation where you have to keep the connections with the community, both on the preventive, promotive, and curative side, going for a very, very long period of time, if not a lifetime. So within the constraints of that type of study, and to address what Priya said about the burden that community health workers have to face with unrealistic targets and unrealistic number of duties assigned to them, given all the limitations, what we found was that 40% of the time was actually spent by the health workers in value-added activities. And 59% of the time was spent on non-value-added activities. But remember, the paper also says they're essential activities, which actually sort of support the patient-driven activities. So it was not too bad, really, to see that they were able to spend nearly about almost 98% or 99% of their time on things that either directly impinged on patient care and patient welfare, and just 1.5% was there for their own sort of recreation or breaks or discussion amongst themselves, which we call completely non-essential activities as far as the project ambit had. Now, when you say what are the non-value-added activities but essential activities, it's the administrative work, it's the transport, it's the writing of reports, and so on, which also comprised of the essential activities. Research projects require documentation, some of which the health workers have to do. But of course, if you go for routine project for program work, that requires also reporting. And we'll talk about that a little more in the next series of questions. But what the single most lesson from this whole research project was that a single tier of generalist cadre of workers may not be sufficient to handle complex health problems like mental health. So perhaps the overall lesson is that we perhaps have to restructure the community health workers sometime in the near future to be able to sort of address themselves to a wide variety of challenges. COVID, for example, which is coming about now. And the single homogeneous, single layer community health worker structure may need to be tinkered with and reformed. Now, coming to the second part of your question, Vinoj, about the applicability to the ASHA worker, there are significant differences between what ASHA workers actually, how they perform, and a dedicated mental health cadre like it was for this research project. So the ASHA workers are part-time, supposed to be part-time incentivized workers. These mental health workers were actually working almost a full day, 6 to 7 hours a day. Many of the times they went over that time period. And the ASHA worker is a generalist health worker, with the mental health worker who's more a sort of a dedicated specialist health worker. The mental health worker, because it covered a rural area, had a very large distance to travel. ASHAs are largely neighborhood workers. So except where the terrain is difficult, like for instance in areas like Sikkim or mountainous regions, then the travel requirements are quite reasonable. But of course, if the terrain is difficult, then of course, then you have to think of how to reach the last mile in isolated communities. Another thing that bothers workers is this whole task of form filling. It's an important task, but which involves considerable time, considering the fact that many of these workers are not very well educated, and the primary education itself is weak. ANMs at one point in time, I remember doing a study in Madhya Pradesh some years ago, they had to fill in something like 23 registers. This was some time ago. And that, of course, is bound to be a difference there in this sort of form filling, particularly for educated community health workers and those that are minimally educated, particularly tribal workers. So there's going to be a great deal of discrepancy within that. But generally, what we do find is that in form filling, that's probably one of the, and documentation is one of the weakest points of community health workers, which needs to be strengthened. But it's not entirely their fault. Partly, of course,
it appears, I think we have... Nerges, can you hear us? It appears that we have lost Nerges. So I think let me move ahead and maybe come back. Shanta, I hope you can hear me.
Yes, I can hear
Great.
you.
Yeah. So you chair the Beyond Beijing Committee, which is a coalition of women's rights, gender justice organizations working to advance the status of women in Nepal. We often associate CHWs with their health-related work. But could you tell us, based on your experience, what is the fundamental role these people, this workforce, play in improving the overall status of women within the community?
Okay. Thank you, Vinod. First of all, I really like to express my gratitude for, and I really feel privileged to be a part of this panel and to really listen to the professional panels from our region. So I'm very, very thankful to the organization. So regarding the questions you have asked, this health worker, community health worker, they are not only the community health worker, they are the nodal group for diverse things, for the diverse issues. And they are the one who really know and understand 3 P's. When I say 3 P's, the first, the ground reality. They know the ground reality and they know from the ground the people. The second, they know the problems of the people. And not only the problems of the people, the potentials of the people and of the ground. Because of this ground understanding of the reality, and they are very, very close to the people, not only women, but all people. They have access to the whole family, the children, the adult people, the women, and the senior, even the faith healers. So many people, they have access, and they are delivering services, not only the health services, but other services and support to the people, especially the women, children, and elderly people in need. Because, and more so, the most marginalized people who can't really afford to go beyond the community because of the various reasons. Since they are the one at the ground level and they know the reality, and they are like a candle in itself. They are the light, and they are giving light to many, many women. And women, and they know and understand not only the health related problem, but the problems of all kinds of problems of women and the female they face. Because of that positions, because they being in that position, and also the commitment nurtured among them, and they really conscientize, create awareness among the duty bearers and also the claimant or right holder. So they really try to empower the right holder and more so of the women, and at the same time, the duty bearer who are in the community, in the local community, the health facilities, management committees people, and municipalities, rural municipalities, all authorities who are on the ground. Because of their positions, they are really able to raise the issue, not only of the health, but the issues of women, like violence against women, children's issues, elderly people issues. They are able to take that issues to the planning and programming of annual programming of the local institution, not only of the government institution, but of all others stakeholder, they being a nodal group at the community level.
Thank you, Shanta. And probably this is interesting. Three P's. Let me, Priya, bring you into this three P's with my next question. What do you think would be potential WHO and other government role to help equip these women, community health workers, with the skills and opportunities to exactly address how they can be more effective in working with the three P's: the people, the problems, and most importantly, the potential of the community?
Thank you so much, Vinoj, and thank you for coming back to me with the three P's. I hope that I'm able to answer your question properly. I think that WHO's role primarily is in providing technical support and guidance. I think we would all agree and note that our primary role is to to review evidence, to develop evidence, to support countries and governments to really identify context specific things. We try to set not only the global standards for different things, but also bring that global standard or evidence to countries and help them contextualize it, adapt it, and tailor it to their specific needs. One of the things that I can say, for example, where we look at people, problem, and potential. I'd like to go back to COVID. During this time, one of the things that we did as WHO, at least at the country office level, is we worked with the women's self-help groups. That is also, I think Shanta also mentioned it, they are also from the community. They are also an integral part of the community that provide health services, if not directly services, but at least access to services. We worked with an organization called Seva, and we learned from them that, at the time, for example, in India, during the lockdown, in the first few weeks, there was very little that was known. I think, people didn't know where to go, they didn't know what kind of services to do. And a lot of women, they may not have been, so well educated or, especially from the communities, everything just shut down. Things just came to a standstill. In that standstill, what really emerged is that, people learned and, we all recognized, our mothers, our family members, women that are in our families that connect us to services. When you're scared of what will happen to COVID, what did you do? Most people went to their moms or, you do not have the access or the luxury to go anywhere. And that is one of the things that we learned from our work during COVID, working with self-help groups, women's groups. We learned, in across 7 states, it was very clear and evident that they are a critical resource, not only in managing or, doing their own household work, but also connecting people. And that just trickles over. Ashas also are women. They also go back home, whether it's Anganwadi workers here or, female health workers in Nepal or even, in any other country. At the end of the day, their social norms, their integration into the society, their own families, all of that remain the same. So as WHO, what we do is bring evidence, generate that evidence, share that with people. One of the key things that we are doing right now is looking at what are the different efforts that, in addition to us, governments across the country, India in and of itself, I would say, is like 35 countries. Like even a small state in the Northeast has done equally well or tried to do that much effort in engaging their people. And this is something that we learn from Seva as much as what something like a big state like UP has done. So first of all, WHO's role and, real work is in setting the standards and guidelines, which we are guided by our global strategy. Second of all is, adapt and, provide that guidance and contextualize it for countries. Specifically, in the case of emergencies, today it's COVID, tomorrow it might be something else. There was a tsunami, there are disasters, all of that. Community health officers, community health workers, they remain integral to that system. because that's, like they are the people who are expected to respond, as well as they themselves have needs and services. So the second part is to really contextualize that evidence. The third one I see where WHO's role and real work comes in is to document that learning. Through our documents, through our guidelines, we provide countries with an opportunity to learn from each other. One very good example I would like to say in this case is, for example, the ASHA workers in India. It's very little is known, and I don't think it's very popularly known, but the Ethiopian female health worker system is actually an adoption of the Indian ASHA healthcare system. So there is an opportunity to learn, to cross-learn from each other, and that is something that WHO does very well. We try to document and present that evidence in a way that other countries and everybody can learn from each other. And finally, of course, true to our normative function and role is to develop training material, resources, and more than an implementing agency, our role is to empower the government. Our role is to support the government in implementing these guidelines, etc. So when it comes to working with people to solve those problems, recognizing their potential, WHO's role is really to build the capacity to engage with the right people at the government level, to equip the community officers to recognize their potential and make sure that the challenges and issues that they face that are so real are actually something that the system is capable of responding to. I think it's very important to remember that whether it's WHO, whether it's an organization, an NGO, or anybody, we are all working towards the same thing. Ultimately, the goal is to make sure that the people that we are relying on so heavily are enabled, they are respected, and they are trusted. And for that, I really think that what WHO has done and does is, work with the government and make sure that we move from evidence to action.
Thanks, Priya. And Nerges, good that we have you back and you come at a right time to field a very interesting question that we have received from Mania, who's been listening to us. Her question is, how do we utilize community health workers for challenging issues like domestic violence during COVID without, and that is the rider she's got, without, and I think it's a very important rider, without significantly overburdening already the overworked community health workers. Nerges, would you like to take a quick shot at this? And if there's anybody else who wants to add on to Nerges, please feel free.
I think you're on mute. Nerges, you're on mute.
Okay, thanks. I think one of the best models for community health workers and their role in domestic violence is the one from SNEHA in Mumbai. And they've been working on that for a very long period of time. And I know about their work reasonably because I was in some of their committees. And I think one of the things that sort of empowers community health workers to actually play a good, important role in tackling domestic violence is their ability to come together as a group. So I think the SNEHA community health workers were also drawn out from some of these microfinance groups that had been formed in the slums there in Mumbai. And apparently, given the right type of training and the inputs, they developed into extremely efficient people who could recognize and suspect domestic violence. And after some time, after having gained good enough confidence, they could even interact with law enforcement agencies to be able to tackle domestic violence. Now, how much that actually can be done without sort of overburdening them? Again, these are sort of dedicated workers that are sort of directed towards handling domestic violence. Now, how a generalist ASHA worker, for instance, can help to mitigate domestic violence in their own local neighborhoods, that remains to be seen. But I think having had the strength of experience, having had the strength of competent functioning within the community, they would become natural leaders to lead the fight against domestic violence in their own communities. without the time constraints that may be imposed on them through formal work. So I think you have to remember anyway that the whole movement of community health workers has come through the empowerment portal, their ability to stand up as leaders in their community. And this training that you give them or any inputs that you give them in specific silos or something only helps to empower them further, irrespective of what type of training or irrespective of the disease. And I think that gives them the confidence to be able to handle domestic violence.
And probably, Shanta, you should take this question from another of our audience, and I'm welcome audience to keep asking us questions through the chat bot. Rishita is inquiring, how is it that FCW's roles could be further strengthened, not by empowering individual at individual level of CHWs, but how do we do that within existing structures of power embedded within the institutions and community? I presume she's asking how can we use community movements, which is your area of strength, Shanta, to empower the female CHWs.
You're on mute.
Yeah, now I get unmute. Thank you for the very, very crucial, pertinent, very important questions. I think this community, especially the FCHWs, they being at the ground level and their potentialities need to be unfolded by letting them not to be led by, but to lead. And that is lead at the community level to address not only the health issue, but cause and concern of most marginalized communities, women, children, and different gender and sexual-oriented people. And that is possible. That is possible to advance. They are doing it now in a very, how should I say, not very effective and efficient and proactive way. But to advance their role, there is a need of additional enlightenment, that is feminist consciousness. As long as these female community health workers, by virtue of being female, they really need to understand and feel the pain and potential of being female. And so that they will put themselves in the shoes of others, and so that they will be really able to lead politically. Politically, that means not party political way, but for the cause of the people, and more so the cause of female being who are being, who have the creativity, the creator or being a creator of human being. So that acknowledgement and that understanding has to be nurtured. If that understanding is nurtured and enabling environment is created, definitely they can really advance further for the cause of not only health, for the cause of women, uplifting women's status pervasively, not only in their own community, since these female health workers are not only in one area, they are pervasive all over the country. Currently in Nepal, more than 51,000 are there. So this is a huge critical mass. If this critical mass is energized further, enlightened further with the feminist consciousness, I think they will really transform the world the women want in a very positive way.
Can I add a few points?
That's fine.
Please go ahead.
Yes, I was just listening, and it's very, very, very useful listening to the experts on the panel. And I was thinking, listening to Nerges, and I agree with her. The whole community health worker model was based on empowerment, creating a space. You had women who lived in villages who had never worked in urban spaces, and because of the heterogeneity, you had people who are not so educated going and receiving status and prestige and being looked at as little mini doctors or as support. However, as we move forward now, and we look at the kind of what's happened with the community health worker, I mean, the good thing is, in Bangladesh, you have 130,000 community health workers. BRAC is about 50,000, government, NGOs, and they're rolling it out, as Priya was saying, in Bangladesh to tackle COVID. I do think this is the time now, though, that we need to look at and reflect critically on how do we really understand community health workers' lives as it unfolds, work-wise, personally, and even within COVID, because I would argue that this is a good time. I think it was Priya or someone talked about opportunities. There's opportunities, I agree. And the opportunities are to document longitudinally, because the pandemic, whatever shape it is, there's going to be future pandemics. And because they are the bridge between the communities, because BRAC and government and many of them rely on them, and they are giving them support and orientation and training. And I want to go back to Nerges' point, any form of training is very helpful. But if we do longitudinal research, you can do rapid, good research over time, tracking community health workers' lives as they're in the field, post-pandemic, after, because they communicate the same way. You can actually empower communities and community health workers. So when we talk about leadership, I find that the model tends to be in general in development and in health. Either it's very biomedical, just virus. So communities are kind of just held up to a model of you wear a mask, you wash your hands, you need water, and therefore you're following. They're living 15 people to a household in a slum. You've got informal settlements in India, in many of these countries. I've lived in Nepal, in Delhi. So I think it's important that the health model needs to be unpacked on health is much broader in poor people's lives and everybody's lives, right? So we need to unpack that disease model, because in many of these countries, even in the West, it's a very clinician-led approach. And that doesn't always work. Then you got community health workers who are the foot soldiers, who are working with the communities, who are the women on the ground. And I think if we could look at a community-centered approach or community-based approaches where you try and understand how do you empower, you can only empower community health workers if communities themselves understand, are mobilized and are heard, and interventions take that into account. I'm not saying do huge scale-up intervention, but even specific contextual interventions are very important in understanding, be it the nature of a pandemic, be it the nature of malaria, be it the nature of dengue, be it the nature of family planning use. Often there's a disconnect. My final point is there are many different actors in the informal sectors, not just community health workers. And community health workers know the pharmacists, they know the drug sellers, they know the homeopathy, they know the Kobiraj, the traditional birth attendants. Community health workers are actually extremely powerful in that role. We found many community health workers were referring individuals to various providers as they saw fit. So they really are at that heart of improving the lives of communities, but also their own. So if we want to improve community health workers, we have to understand their lives first. We have to really understand and prioritize their needs in terms of workspace. So then maybe organizations, some are already doing it in Bangladesh, some could improve. I think we could all improve. My research could improve. So I'm just making a general statement here. Supportive supervision, a training that's focused on particular areas of communicating in ways, coping with, pushback from certain community members or leaders, or, I really think because you have to work in a network. A community is heterogeneous. So if I, as a community health worker alone, is tasked with something, but the drug seller doesn't believe me, how do you work in that community? So I really think we need to think more comprehensively, but it goes back to Vinoj, your original question, which is, if we look at community health workers as the heart, the bridge to communities, how do we then, in a very comprehensive way, empower them? Research will provide evidence for WHO, other organizations. Research also is really needed to fight and give that voice and agency for the diversity of community health workers, whether you're in a rural village in India or Nepal or an urban space, very different spaces. Two, it also it also actually brings to the forefront where you have community health workers co-creating and thinking of practical, feasible solutions. So I would just say that I think when we think about empowerment, we use that a lot, and I completely agree with Nerges. If the model was to empower community health workers, and we rely on them, they are the bridge. How do we then create the evidence in the space to really do concrete things? Because we're going to keep having pandemics, and for the poor, the pandemic is just another disaster. For us who are well off sitting and Zooming, it's the biggest disaster on earth. Let's face it. The inequalities existed for centuries. It's just magnified now because of COVID. And the reality is we should take food for thought and say, what can we learn so we can do better to strengthen health systems, but to strengthen community health workers and communities? It's a shock for the middle class and the elite. The poor all over the world have been having a really hard time for a very long time. And I've been working in Bangladesh for 25 years. Earthquake, a disaster, a fire, floods, coronavirus, you've got dengue, you've got, so I'm sorry, my empathy lies with the vulnerable groups, because for once it's turned on us. It's a global pandemic, but we're still better off. We have food, we have a job, we can sit at home and Zoom. I'm going to wrap up with just that. Thank you very much. I feel very strongly, so this is my personal opinion as an academic and a researcher. We need to go back to the basics and really critically reflect.
Thanks.
Thank you.
Thanks, Sabina.
Just a quick one. Could I add on to this, if I may?
Very quickly, Nerges, because we are getting
so
close
I
to
think
the...
one has to realize the evolution of the inputs that have been given to community health workers. It started with the informal, and that of course gave them a lot of empowerment. Then it went to informatic training, then formative training. And now we have to look at, with the pandemics in front of us and the uncertain future, you have to look at the transformative training. Also, the transformative inputs that will make them from workers to leaders for their community. And I completely agree with Sabina, where you say that you need research and you need to look deeply into their lives and their needs and their aspirations also, to be able to, for them to do a good community engagement and to be able to be creative in finding local solutions. We've been too prescriptive in our trainings. What you need to actually make them do with the background of poor education, change the method, make them, instead of training them, make them learners as to find their own solutions and to make good decision-making at the local level. I'll stop there. Thank you.
Thanks, Nerges. And very quickly, let me ask to accommodate a question, an interesting question from the audience, and a very quick response. And it's a very direct question. When we are talking about community health workers, do you think we are fairly compensating them? And I think the question comes from the whole conversation all of you have had around the COVID-19 pandemic. So is the front line being compensated? And I think let us just a quick, because it's been asked, would one of you want to just give an yes or no answer to a question? Because I know that we can go on and on.
Shall I?
Yeah.
Yes, please.
Definitely not. And that's the reason. If we really, really want community, basically the female community health volunteer to perform at the utmost level, we really need to recognize, respect their rights to decent work status. Currently, in Nepal case, they are still recognized as a non-health professional worker. They are not paid, they are volunteer. So we really need to recognize, respect their rights to have a decent work and decent environment. Without that,
Thanks.
Otherwise we will be really exploiting, not really acknowledging them, their rights as a rightful person, as a rightful work they are doing.
Thanks, Shanta. And I hope that addresses your question, Nalini. My real sincere apologies to Nagaraj, Manya, and others whom we won't be able to get into your questions now. But because we are running out of time and I would like to bring a closure to this session. So I would like to close with a personal question to each one of you. If you could, in a single line, it's very clear how much you care deeply about creating a system that supports, protects, and empowers the community health workers. If there is, if you could change one thing about the health system, or rather now as the conversation went, the whole ecosystem of the community to support female health workers and empower them, what would it be? Just give me that one item wish list of yours, please. Priya, would you like to go first?
Sure. If I had to wish for one thing, in the whole system and to change it, I would pick balance. I would pick a balance between expectation versus reality. I would pick a balance between funding and utilization, investment and opportunity. I would really pick a balance between integration of community health worker into the system versus what is expected of them as an outcome. So I would look at the balance in the health system. I think Nerges talked very well about the evolution of the system. We started with them being volunteers, and we've come all the way where, in India at least, there is an opportunity with the Ayushman Bharat scheme or with the health and wellness centers where you are remunerating them in some way or the other. So I think moving forward with everything that we've learned from COVID, if we can balance this and really evolve into a system or a structure where women are respected, not only women actually, it's the men and the women, the entire structure where there is respect, dignity and trust in the system, I think then we've achieved a lot. So
Thanks.
One thing would be balance.
Thanks, Priya. A 30-second response from each of you, please, because we are running into a timeline. Shanta, next. 30 seconds.
Dignified, decent, enabling environment for community health, female community health worker.
Perfect. Can I move it to Sabina, please?
I would say a socially just model that looks at human rights. That would, if you have that framing, it would change the way you do research, the way you approach community health workers and even health systems from a community-centered perspective.
There we go, Sabina, a framing issue. And Nerges, what about you?
So I sort of have an acronym called RUS. R stands for respect, which many of you have talked about. The second is upskilling. That's the U part of it. And that's also we have talked about. And the third thing is support. And the most important thing in that support means consciously include their voice in decision making, finally, to make an impact. Thank you.
Thank you once again for being there. And it's been a real wonderful pleasure interacting with all of you. Thank you.
Thanks.